All right, thank you very much. So tonight is actually 2 years in the making for Ventilation Matters. And we're now spending 2 holiday seasons together. And I thought it would be a great idea, speaking with Graham, if we would get together and just kind of have a fun session where we try to figure out what's going on, what's wrong with the current state of mechanical ventilation, and what we would do to improve things if we were king of the ventilator world. So with that, I'm going to turn it over to Jeff and let Jeff, who's one of our original guys, start us off.
Okay. All right. What are we doing wrong? It's a really brilliant topic. And it's difficult to know where to start. But all I would say is that we're doing a lot wrong. And I was lamenting only a couple of weeks ago, almost with a tear in my eye, that I don't know that in Christchurch we have actually changed the way we ventilate patients since I was a very junior registrar. We still have people on SIMV. Graham knows of this. You come in and you see a patient with a lot of dysynchrony and hypertensive and lots of sedation, and the inotrope's been turned up and they look bloody awful. And you see they're on SIMV volume control. And I think to myself, And then I realized that, in fact, that's what we probably did 30 years ago. We had a little bit of pressure support sometimes. And I remember reading about a review on pressure support when it really first came out. This was in the mid-80s, and presenting it to our journal club. And what I think is very sad is I think we're kind of almost stuck in a intellectual ice age. And that is that there is a huge separation now between the people like yourself who are avant-garde, who are going out there, breaking down barriers and finding more interesting and better ways to ventilate patients, and actually what is happening at the coalface. At the coalface, there are many nurses who, at least in New Zealand, Australia, and I think the UK, are in charge of the way ventilators are run, whereas in the US, it's a different model. But unless you get all those people on board and all educated and of the same mind, then you can only, then your ventilation is only as good as the weakest link in the nursing team. And that's because our ventilators are manually set most of the time. They're not that intelligent, in spite of intelligent ventilation, quote unquote. I think the answer is quite different for what you might normally expect. Apart from the fact that we need to get the software out of the ventilator, I believe, and make it more universally accessible, and make it also agnostic to the type of ventilator that you have, because every ventilator company will have their own bit of software, and they'll call every mode of ventilation something slightly different. And from the end user point of view, it just confuses the shit out of people. It's like jumping into a car and having different controls every time you jump into a new car. But I actually think that the answer is different. I think we need to have a cultural transplant, a cultural change within our nursing staff. And this is where I think they have to take back control of the patient. At the end of the day, I think the nurses are more analogous to a pilot flying an aircraft, let's say a 787. And my role is more like the air traffic controller. Well, that's at least how I see myself. I might set the direction, and but the nursing staff are there to manage all the turbulence and all these sort of, minute by minute issues. And the nursing staff are also there to optimize the ventilation. I believe they should be the ones who given the right tools and education, should be doing that at the bedside all the time. So that is, I think, the direction that we need to move. That is nursing staff owning the problem. At the moment, a nurse will come up to me and say, well, actually, they won't come up to you, say anything. You just walk up the ventilator. And there were 2 patients I saw during a handover for one of my colleagues. And one patient was on 10 centimeters of PEEP on 80% O2 that I recruited up and got them down to about 40%. And then the next patient, I noticed that they had a very long respiratory time. They had about, who was on high doses of inotropes, and they were spending about perhaps a sixth of their time with a PEEP effectively of about 25 centimeters of water. So that was no good. So there, and no one actually had noticed this. So if you had the staff taking control, owning the problem, having the correct tools so they could optimize ventilation, whatever they might be, and what we think is going to work. That, I think, is the future. And one of the things that my colleague Jeff Chase and I have been talking about is this concept of digital twins. That is that you can take physiological parameters in a patient, and they could relate to ventilation or circulation or sedation or whatever, and you can put them into a computer. And then if you get the model correct, and all models are wrong, except some are better than others, as they say, but even if the model is sort of 95% correct, if you have the right model, you can then predict what will happen when you make changes in your ventilation. And so if we use a digital twin type of philosophy that digitizes, parameterizes patients' physiology or pathophysiology, that is then predictive, it then is a simple step to let the nursing staff be then in control of what happens, so long as you set the right guidance. So I think that's my 10 cents worth. It's a very ambitious sort of plan, but I think the only way we're going to get there is to do a number of things at the same time. We have to empower our nurses more. We have to educate them a shitload more. And we also have to find tools within our ventilation armory that allows nursing staff to be better informed about the mechanical state of the patient's lungs, so that then they can make the correct decisions.
So Jeff, can I jump in?
Yes, I'm finished.
Thank you. That was a very nice launching pad, by the way. I thought I can't hold myself back until you finish. Now, I agree with you, but I think you missed I think part of it's right and part of it's not right.
Right.
And it's, Steve and I, respiratory therapists, so we're a bit different on this. But the point is about doctors, clinicians in these countries, is that most of them are not taught ventilation properly. So for an example, if you ever used volume control SIMV, and I think globally, it's the two countries that use it the most are Australia and New Zealand. Most countries have stopped using it a long time ago. Personally, yeah. I don't rate SIMV. I think it's a crap mode. When you have a mode that combines volume, a fixed flow control volume, and then a pressure support breath, different pressures, different volume, and so on, you've got the synchrony the whole time. No one understands synchrony. What is synchrony? So they end up all sedate the patient, fighting the ventilator. So you've got the clinician at the top who doesn't understand the intelligence of new modes, number one, but modes that are far superior. SIMV was developed 30 or 40 years ago, right? And now we've got like a Tesla stealth technology that can support the patient correctly, right? And these guys are, they're still using 30 or 40 mindset. So the nurses, have worked with them. They know what Dr. A likes or Dr. B likes as SIMV. And so to say to somebody, the I to E ratio is wrong. Well, how do they know it's wrong? I mean, one of the things I like, my interests are I time. How important is I time? Oh no, we just look at E time. So if you have an I time of 1.5 seconds, the guy halfway through say, I need to exhale. All this sort of stuff, right? Or it's the same thing too about setting PEEP. I know we're jumping a bit on this, but setting PEEP, everyone's number 5. Show me the RCT on that number 5 was the right number. There's no RCT at all. What's wrong with 4? What's wrong with 10? Come on. There's a lot of stuff that is not being taught. In New Zealand, Ross Freeburn, which is on board here today, runs the basic course. He runs ventilation courses and teaches people. But I really wonder, and he goes beyond New Zealand to other countries teaching them as well. And he talks about new modes as well as conventional management. But I'd go back to your country. So why the heck are they still using old-fashioned modes? I can't believe it. I'll give my sense with Jeff.
Okay, Graham. I'll give you one reason. I agree with you. I agree.
That's it.
Okay, I agree with just everything you said. And it's the doctors are equally to blame. In fact, I can tell you that the intensive care curriculum, the training of specialists puts no emphasis on ventilation at all. And I was never trained on ventilation, just that I was curious about it.
Yeah, but sorry, Jeff, I'm going to jump in. You and I were lucky, and so was Ross, because we worked with Keith.
Yes.
who taught us a lot about ventilation, and Steve knows him as well. This guy
Yeah.
was very unique.
Yeah, and I worked with Andrew Burston as well, and
That's right.
they both inspired me.
Yep.
So yeah, you're absolutely right. The doctors are not interested. Just going back to the anecdote, on my same ward round, someone on the Draeger ventilator had switched off the Autoflow. I don't know, for some strange reason. So no one had noticed the patient's flow had a square wave pattern. And this is a patient who had all this dysynchrony. And I said, well, what the hell have they done that for? Oh, I don't know. Most people wouldn't even know what Autoflow was. But that's beside the point. The point was that the ventilator allows absolutely suboptimal ventilation. It says you doctors obviously are very, very clever and you know what you're doing. You can ventilate the patient in the most shitty, dangerous way, and I will not complain. However, I will have alarms that will drive you completely nuts, because I will have alarms for every single little pressure transgression, but I won't tell you whether or not you're actually ventilating the patient well. So it comes back to I think it is a cultural thing. We have to get doctors more interested in ventilation. And the question is, why not? Why can't we inspire our colleagues to actually think it's important? And I think part of the problem is the way that we're taught, where everything is, the important things in the world seem to revolve around a clinical trial, randomized controlled trial. But it is extremely difficult to do a randomized controlled trial in ventilation when every ventilator has kind of got bespoke software and it was all slightly different. And we don't have universal tools that everyone follows for ventilating patients. And so you end up with, again, ventilation at the lowest common denominator. And also ventilation trials are enormously intensively difficult to run, because you have to invest in the training of everybody. It's not like just, someone comes along and Paul Young does with his Mega Rock study. Oh, we're going to ventilate a patient on with saturations of 91% versus whatever it is, 95 or more, which is a very, very simple thing to do. You just turn the oxygen knob down a bit, and that's all you have to do. If you want to do a ventilation trial, it has to be, it's a million times more complex than that. And getting people on board is difficult. And finally, one of the things I was lamenting is the fact that in New Zealand, Australia, the UK, intensive care really doesn't get much investment. There's a little bit more now because it's politically embarrassing for the government to be caught with their pants down, knowing that we have the least number of resourced ICU beds in the Western world in New Zealand. And now the politicians are saying, well, what are we going to do when we get this, COVID surge, which will eventually happen in this country? And so finally, it says, okay, look, you've got to expand out your intensive care service, which we are now doing. But one of the problems is that they're going to keep investing in training more nurses to a very, very basic level. That's great for a pandemic, but it's not a sustainable way to go. And if you cannot train your nurses and you don't get the investment in nursing training, you are stuck. It's like someone taking out your bloody memory and making you demented. It's like someone taking out your temporal lobe so you can never learn anything new. And that's really what it's like. Actually, that's a good analogy.
It is a good analogy.
And that's what it's like in this part of the world, Steve. The lack of investment, the lack of people's placing importance on ventilation is a huge problem. It's the culture, the lack of money, the way that ventilators are set up, the fact that software and the ventilator are combined as one. You can't pull the two apart very easily. We don't have agnostic software, ventilation, and we don't have universally agreed upon modes. So I would like to hope that we could make a ventilator like a bloody motor car. I can jump into a car anywhere on the planet, and I know that the gear, even if in a left-hand drive car, for example, the layout is still the same as a right-hand drive car. I know that the brake pedal will be in the center. There's a big one, and the accelerator is to the right of it.
Some level of uniformity. The only thing that I would say that would run contrary to that example is that I sat in a Tesla for the first time yesterday and realized there was nothing to control. There was this giant interface panel, and I said, I don't know if I would buy this. I need control. I want control.
Yeah.
But anyways, I'm going to keep my mouth shut until the end. And Dr. Dawood, would you like to let us know what you think might be going wrong in mechanical ventilation and what you would like to change if you could?
Yeah, okay. So I would totally agree with what you guys are saying. Like, I think, number one, change is very hard, very difficult. Like even in the US, which, I came from Egypt and things, you're the doctor, you say this, we're going to do this, and we'll do this. In the US, things are different. People do not accept change very quick, don't accommodate. An example for this, back even in the early 2000s, and I love APRV, and I have people with ARDS, and I'll try APRV, and the resistance from everybody is like physicians and respiratory therapists, like, wait, no, we don't do this. We don't know what is this. And therapists and doctors, and I tell them, well, you're supposed to. It's an old mode, been there for 20 something years at the time. You should know it. It's on the ventilator. So that's one of the big obstacles, resistance to change or accept some changes. The second thing I think one of you pointed up is the lack of interest in mechanical ventilation. And I sat as a program director for the Critical Care Fellowship in Cleveland. And it's amazing how pulmonary fellows, critical care fellows were not interested in the ventilator. I hate to say that it was mostly from the pulmonary, because combined pulmonary and critical care, which honestly, I think it's something should be, it shouldn't have been done from the beginning, but it's time to separate them because this is a specialty and this is a different specialty. Nobody was interested. As long as the patient says okay, let whoever, it doesn't matter. People 5, people 2, sets 92, it's good. So that's a problem. So it's lack of education, lack of interest from physicians. Nobody wants to spend the 20-30 minutes to get things correct and look at the patient, the interactions, the synchrony, the respiratory mechanics, right? Again, as long as the ventilator is not beeping and the patient has like good sets and good pH and stuff. So nobody wants to take the extra step. Is like, oh no, it takes more time to figure out what's going on. So it's a mental, culture, educational, multiple things to change. Maybe, I don't know, maybe it's not a lucrative business versus like, to spend so much time on a ventilator when, you're short-staffed and you don't make money versus you can go see 3-4 patients at the time or do a bronchoscope and get embarrassed more. I think it's just the problem has so many deep roots that can't be all tackled at once. The other problem, which I see it like back in 2000 when the ARMA trial came, and the solution was low tidal volume, and everybody started was like, oh, 6 milliliter per kg, whatever, PPFiO2 table, done. We don't have to think, we don't have to investigate, we don't have to, and that's it. It became like they made a complex problem, very complex problem. Yes, make it so simple. And I always used to tell the residents and the fellows, if the answer is so simple, it's probably wrong. If it's just all what you have to do to save the patient is just make him 6 milliliter, it can't be. So how to start or how to fix these problems? My God, I mean, I think we need to start from so many, not from one single point, but from so many different points. Get people interested, get people maybe in some incentives to do it, invest in education. I don't know where to start from, but that's my point.
I couldn't agree more. I suggest that we and others perhaps write a paper on this, because I think it's a really, really, really important topic. The most important thing we can talk about is what are we doing wrong and how do we fix it? And I just think some of the things that have come out, I've just been making some notes. The resistance to change, the lack of interest, the lack of education, and I would say the lack of curiosity, and I'm going to come back to that. I'll talk about it now, is the lack of curiosity is something which I've noticed in medical students. I work with engineers, and they are a completely different breed of beast compared with medical students. Medical training seems to be just all about telling students what you need to pass the exam. Oh, yes, there are other things that they consider are important, but their minds are all built on heuristic models. no value in actually any deep thinking about anything at all. And I think medical school is probably, for me anyway, was the biggest turn off of my natural curiosity about anything. It took a long time for me to get reinterested in things like mechanical ventilation and to think about physiology, and actually having the confidence to actually understand it a bit and apply it at the bedside, which is actually quite a big step. So the question is, how can we make our medical colleagues and our nursing colleagues more curious about the patient in front of them? What is it that gets people's curiosity? And I think we need a psychologist here. I can't answer that question. I mean, do we turn ventilation into a game? Do we have parameters that everyone can understand, and then it becomes a competition in some way? Look, my patients, lung stress, whatever number of units are lower than anybody else's because I'm actually fairly cool. I'm hot here. You know what I mean? If you have some sort of feedback mechanism that actually made people take ownership and concern about their patient and made them curious about how they can actually get it better, then I think we might get somewhere. And so it's a psychological problem as much as a technological problem, as much as it's a physiological problem.
So Jeff, it's a good point. What about things like sedation usage, or time on the ventilator mode versus current ventilation versus changing to another mode, and they look at patient comfort or something else.
Okay.
Which means it's real, right?
Yeah, Graham, that's a really good question. One thing which I have been always interested in, and it's really boring, and I must say as a registrar, I found the most boring thing out is sedation. And in fact, if you look at TECO's 3rd edition, which was my Bible for my exam, which I sat in 1993, these chapter on sedation was the shortest one in the book. I think it might have been, a few paragraphs, and that was it. But you go up to the nursing staff, and again on my ward round last week, I was kind of exasperated by patients who would be lying in bed, spontaneously breathing, with a poorly set up on the ventilator, with a lot of adrenergic stuff going on. They'd be sweaty, they'd look terrible, and they'd be ironed out. You say to the nursing staff, look, I want sedation, the RASS score between -2 and +1. That's what our standard is. And it's -5 here. And what's the reason for that? Oh, well, they were a bit desynchronous, or they were a bit, unhappy, or whatever. There's some sort of loose word like that. And I said, well, if they were, why are you not writing it down on the chart? The chart's got to tell a story. It doesn't tell me anything. I said, if I did an audit of this, I'd say that you're overly sedating that patient. I said, look, let's turn off the fentanyl here. Do you realize you're giving 4 cardiac anesthetics every day to this patient? I said 4,500 micrograms per day of fentanyl, I'm sure, is too much for this patient. Years ago, I looked at sedation use in patients, and we had an automated system that never lied, and patients got twice as much sedation at night than they did during the daytime. And I did wonder why, just because of an astronomical phenomenon like the Earth happens to be facing away from the sun, should mean that patients become more agitated at night, and especially when they should be asleep anyway. But that's because the nursing staff like to snow the patients at night. And that's why we have this sort of, this idea of having a wake-up, test, flick the sedation off in the morning. That just reflects bad practice. I don't think it's actually generalizable to units that actually have good sedation practice. But going back to your question, what about sedation? Yeah, if we had nursing staff more involved and with greater understanding about the level of drug that they're using and how much they're using and how much that could be harming the patients, then that also is really important. Because if you have a patient who's desynchronous, who looks, crappy on the ventilator, and you think the solution is just turn up the fentanyl and the midazolam or morphine or the propofol, then you've got a problem. So again, it's all about getting these models of care right, and it involves people being curious and investing the time in the problem and owning that problem and taking responsibility for it.
Can I add something to what Jeff, sorry to jump in. Is that okay?
No, please do.
Yeah. When we were talking about education and lack of interest and all this stuff about ventilation, and I think I shared it with you and Graham before, I had a thought for some point is to do a fellowship in mechanical ventilation. I think we talked about it. It's just like a brief idea. We're basically just the whole focus to be on mechanical ventilation, including sedation, including synchrony, including the, the mechanics, how to adjust the ventilator and everything. And in my head, it sounds like a good idea. Of course, you have to be interested to like go deeper into this. And of course, it's not, it's an effort that will need a lot of collaboration from multiple people in different, you know, places and different to make this possible. So I think this is a good channel to like, you know, maybe throw that idea at.
I think, Ehab, I think it's a good point, because the closest I can come up with this at the moment is the basic course, you know, that Ross runs, which is he focuses on ventilation, but not everything. Or globally, there are, through societies, there are courses, right? There are courses, ventilation courses. Big, you know, I mean, I can see Andreas is on us. Hi, Andreas. But I can remember one time he and I went off to, this was some time ago, off to Korea at the Arson Medical Center. They ran like a 3 or 4 day workshop with Young Suk Ko and those guys. But they were very focused 100% on ventilation.
Mm-hmm.
And I think that's part of that's missing. That where you go to a congress, and I mean, it's not fellowship, but even congresses, it's only a small part of is really focused on ventilation. But the fellowship thing, how you teach ventilation, is so important.
Yeah. Yeah, you're right, and there is definitely multiple societies and like the SM, there's ventilation courses and stuff like that. But again, I think it's also sometimes driven by like the ventilator companies, like, you know, influenced by that. You know, like say again back to that ARMA trial and the ARDS, like you would see that all the teaching, all the literature coming is just targeting, oh, you're not using the 6 milliliter, you know. So it's not really like invested in much of like the, you know, the depths of mechanical ventilation per se with all its so yeah, just thinking like something comprehensive from A to Z and build on it after that.
So let me jump in and thank you, Andres, for joining us. Where we are sitting is we asked the question, what's wrong currently in mechanical ventilation? And what would you do if you could change things? And we heard from Jeff and from Ehab about the lack of interest in mechanical ventilation, the lack of curiosity, even in the curriculum taught to medical students. We also heard about the lack of curiosity at the bedside among those that might be taking care of mechanical ventilation. And we actually heard one of your analogies I've heard you make from Jeff regarding the airplane piloting, and that he's kind of sees himself as the control tower or the chief pilot, and the nurses are left to mend with and manage the turbulence and to get from A to Z, and there just doesn't seem to be support or uniformity or even intellectual interest at this time. So with that, if that's a fair summary at this point, I'll ask you, what do you think is wrong with mechanical ventilation, and what would you do to change it, or what would you change?
Probably to answer that question, I would like to go back into a little bit of history. I did a lot of neonatal ventilation and prematurity ventilation back in my training years. And in the world of the neonatologists, they have made huge progress and have seen good outcomes and reduced problems with mechanical ventilation. And they have probably paved the way, you know, of small tidal volumes, take care of the lungs, don't ventilate if you don't need, etc. And if you are a trainee in neonatology, ventilation is a cornerstone of your training. So in the neonatal world, I would say that the interest in mechanical ventilation is existent, and knowledge is quite profound. And now, why do we not have a similar interest in intensive care? And you know, having now done 30 years of pediatric intensive care as well as some adult intensive care, it's a little bit, we haven't seen that progression of, we don't see the results. And I think it's a bit frustration, even amongst ourselves, that we still argue how should we ventilate. And we're not taking any more as serious. And I think it may be Albert Einstein's, if you keep making a mistake over and over again, it's called insanity. I think that the gurus in mechanical ventilation have initially had, you know, around 2000, 2002 Amato studies, a little blip of hope. But over the last 10 years, that hope that we can improve outcome has just not translated into the clinical environment. We haven't been able to demonstrate that we can have a breakthrough. You know, it really saves life if you do such and such. And interestingly, if you follow the recent publications with the COVID ARDS, where a more specific phenotype approach has had to be chosen. So the hyperinflammation state with the interleukin-6 treatments that recently, the REMAP study that's been recently published, you know, there may be some hope that we start getting again some momentum going, that it's not necessarily only the mechanical part of ventilation, it is as well the biochemical part of mechanical ventilation that is important. So if we in future look more as well, not just at pressures and volumes and synchrony, that we look as well the biochemical interaction and how we can treat, either as a causative factor or as a resulting factor from mechanical ventilation. I think it's a bit of frustration that we haven't seen, you know, a breakthrough, and that has been translated, oh, no matter what we do, the patient either survives or doesn't survive. You know, if you believe in high PEEP, low PEEP, you know, small tidal volumes, I think it's confusing for the average clinician to understand, and that's, I think it hasn't translated.
Andreas, that's right. I can recall over the years you and I have had lots of discussions about ventilation modes as an example, like noisy ventilation, which is, or any physiological approach to ventilation, and how many clinicians actually take a physiological approach to how they ventilate. Or they look at the blood gases, is that enough? You ask them, well, would you look at compliance or something else on the ventilator, which is telling us something? And, you know, I think it's very complex. I mean, I suppose if you got taught from a neonatal perspective, the lung pathology is very, very different, because most of them are probably on ventilators where, you know, a lot of ICU patients like sepsis or whatever, they're just on a bit of oxygen therapy maybe. And so I think the diseases are different, but yeah, I would say that what you've said is right. We have to rethink what we're doing. And I mean, I don't want to look like I'm going to flog the horse here, but what Ehab said too about how you get taught ventilation, and it's not just 6 mils per kilogram. Now we talk about things like power and driving pressure and so on, may be far more important, and then the blood gases will improve over time. You know, instead of saying keep the peak pressure at 30, because that could actually, that may mean plateau pressure, or maybe not. You know, there's that issue over there. And how many people, I suppose 6 mils per kilogram has shown a lower driving pressure, I suppose. But now you say maybe it's not quite right, maybe it's power, which is an overall, overall thing, and you show them the formula, and most people go, this is far too complicated.
So what would you do, Graham, to change things? What needs to happen from your perspective?
I would say give up the career and do something else, become a pilot. No, I think though, you know, going back. So I mean, you know, we're all friends here in this thing, you know, and we've all had discussions before on ventilation. What should we monitor? What numbers are important? So that obviously the displays of what ventilators do, I think is very important. Most of people say we have 3 waveforms, numbers, and so on. And most people, I think, struggle with waveform technology. They look at one value, not the three values combined. The numbers, maybe they're just too much. I think showing ventilation in a different format, like a graphical approach, like an animated lung concept, which takes into account things, is a lot easier for clinicians, because not everybody's a ventilation expert. Personally, I like the idea of the newer modes. I think newer modes are safer than the old modes, but that's just my opinion.
Hey, what do you guys think of the fact that we could, and we could still do this? If you're flying in a 787 around the world, Graham, as you used to before COVID struck, the engine was continuously pinging satellites with all its data. And that was all going back to General Electric or Rolls-Royce or whoever manufactured the engines. And so your aircraft was being monitored by some artificial intelligence the whole time. Now, what about having some simple metrics that we could all agree on at the very beginning that are collected on all our patients, that are anonymously or in a way that the patient identity is well and truly stripped out and is monitored collectively, and we could compare how our own ICU is doing with other ICUs, even things like, what is your average tidal volume? What's your average PEEP? What's your average FiO2? What's your average saturation? All that sort of shit. At least it would give you some idea as to where you stood relative to the rest of the world. And but that's only the beginning. I mean, ultimately, I can't see why we couldn't have systems in place that allow us to have uploaded data onto the cloud that allows us to compare ourselves with, if you like, the collective ventilation of similarly matched patients throughout the world.
I'm going to throw this to Andreas, because it was a project we did before on big data. And I think you're the expert, Andreas. I'll let you reply to this because it was something that I know that you were passionate about before.
I wouldn't say I'm the expert at all, but I would absolutely support such an idea, because the idea that we were generating is that with artificial intelligence based on a continuous measurement of data would probably help us to better understand the different, I'm using the word again, phenotypes in mechanical ventilation. So not just only ARDS patients, we're talking here as well about post-surgical patients. They may go into ventilation issues, etc., etc. The idea was that such a system should not only feed data from mechanical ventilation, it should feed as well, obviously, the resulting factors such as the gas exchange, but we need then to have information on the cardiovascular system, and the data needs to be basically then as well captured and stratified or grouped with patient information. And I would go even further, that the data needs to be captured with who is looking after these patients. So, a senior, a less senior, only the nurses, or is there 3 nurses per 3 patients, etc. So I think hospital factors should go in there as well, and should even environmental factors that patients presenting in South America are much more likely to have an infectious trigger, have a delay to present to hospital, come into the intensive care much later stage compared to us. So cultural factors as well. I'm pretty sure if we were to have a randomized controlled trial using an artificial intelligence algorithm that takes knowledge, environmental factors, physiological factors, medical nursing factors into account, and would give the clinician a proposal of how to ventilate and what to do versus standard care. I'm pretty sure I will put my money on an artificial intelligence intervention compared to standard practice. It would be a humongous project, but it would be fascinating.
But I think, Andreas, that's really great. You've made me curious about one other thing. None of the clinical trials really focus on the burden of care. That is, how much time is spent by the person at the bedside having to drive the aircraft. And I think that is becoming increasingly more of a problem as we face ICUs, which are overloaded, say with COVID, or the next, pandemic is probably only, another virus away or a variation away. And constantly our admin people in the hospital are pushing back at, and they see intensive care as being very cost intensive. And as if you're an economist, we're non-productive. We have not fundamentally changed much since 1950. So I actually think that I'm trying to find a key here that could revolutionize the way we deal with ventilation. But I think we have to think about the justification for the intensity of the intervention at the bedside. Now, if we have artificial intelligence, and we have a whole lot of intelligence that actually advises the correct way of ventilating a patient, that would vastly reduce the burden of care on the person at the bedside. At the same time, it would improve the quality of care for that patient. Now, there is dollars in that. Even just reducing the burden of care translates to more money, more time saved, and more patients treated, regardless of whether or not that individual patient actually benefits. If you could argue that you could treat more people because of a reduction in workload, then you have done something equally as important. But that's not what clinical trials are about. They're all about the individual. So we need to change our focus.
Yep. Let me jump in here and take a shot at this. Again, before I start on saying what's wrong, I want to say I'm grateful to the professionals that are willing to look at this problem and put effort in to try to make a change. And I'm certainly grateful to this team that shows up every time we call out and ask for interesting subject. And I'm also very grateful for some of the new professional societies that are coming up that are focused on mechanical ventilation. Ahab, thank you very much for that. I'm wearing this shirt for this presentation today. This is the Punisher shirt. And the reason I'm wearing the Punisher shirt is because I left ventilation for a period of time, wanted to focus on asthma, felt the burden of asthma, pediatric asthma was something that needed to be tackled. But because of COVID, moved back into mechanical ventilation and disappointed to find that things haven't changed. What I think is wrong really is one simple number, our mortality rates. Our mortality rates remain the same. I just recently was looking at writing a paper and trying to put together a series of views on changing mortality. And as I began to read, I realized, there are those COVID papers that are a little bit outlier, claiming 50 or 75% mortality. But the real core level of mortality remains around greater than 30% for adult critical care. And I think that is something I don't like. The other thing I don't like is, and I did the article on ventilator malfunctions, it is the amount of ventilators that are malfunctioning or that the clinician believes are malfunctioning. And when you really do dig into the data that's presented and data that's captured at these malfunctions, you realize the clinician didn't understand what they were doing with the tool that was presented to them. And therefore, if it behaved differently than what they thought, they believed it was a malfunction of the technology. And so that, to me, was disturbing. And when I sit and think about this, I realize, and this is in kind with what everyone here has said, I'm not sure we have the right, in athletics, we have key performance indexes that we measure, and everybody comes under the microscope to be looked at, the coaches, the players, and at the end of the day, it's scoreboard. It's did you win the game? And I'm not sure we have the right focus on what needs to happen. I also agree with Robert Chatburn, who wasn't able to attend tonight, but sent us some information saying we don't have the right education in place for caregivers. And we need to, in some ways, train those at the bedside like we train people on ACLS or PALS. It needs to be regimented, and it needs to be rooted in their foundation. I think we've just allowed things to get too complicated, and academia has created many hypotheses about what we should be doing or what we should study. And I think we've kind of gotten off track. My particular bias, as everyone knows, is I feel mechanical ventilation should be simple there. And we need to embrace technology like EIT and like InspiWave and these sorts of technologies and not be afraid of them. And I think ultimately people don't become interested until they have skin in the game. So we have to figure out a way to put skin in the game, these caregivers to have skin in the game at the bedside. They need to be just as, rewarded or not based on the success of their patient care.
Yeah.
That's my pontification.
That's important, and just something light to support what you said. You were saying about what have we learned in 30 years or so, and who knows? I can recall about 20 years ago, one of my many Chinese trips I gave a talk on lung protection, and this doctor said to me, how can we reduce our mortality? He said, we have all these people who die on ventilators, and he was saying it, but just a discussion. And I said to him, well, the only way that I know that you can reduce mortality is not to ventilate sick patients, because that's just the risk of what happens. If you want to just treat healthy patients, you'll have good outcomes.
I mean, I personally haven't been exposed at all, but just reading COVID and the use of invasive mechanical ventilation has questioned again, the validity. I mean, how insane is it to mechanically ventilate? Because as soon as you start ventilating, you're going to injure the lung, and
That's
of
right.
course necessity. But you shouldn't forget. I mean, if you I work in a cardiac ICU currently, and how do we monitor cardiac output, adjusting inotropes, blood pressure? We're doing it very similar in a very blind way. We look at that red waveform on the screen with the upper number and the lower number. We look at the lactate. Is it going up, or the metabolic state? Yeah, okay. Mixed venous saturation, yeah, looks okay. But we don't have a much more insight in cardiovascular management than in mechanical ventilation. And I think we're compared to, let's say, cardiac intensive care management, in mechanical ventilation management, we're not far behind, not actually understanding what we're doing. And so I think the idea of having a bigger picture, understanding that is captured with technology that we as simple-minded physicians may not be able to, that a computer modeling can actually tell us. The computer modeling is, if you look at the Lancet paper from 2017, where they looked at, I think it was the alveoli and I can't remember other study, where they classified the phenotypes in ARDS, and you couldn't do that. As clinicians, we were not able to cluster our patients into two groups. So we needed this mathematical model, which is, I've been told, over 100 years old, this classing model. It's probably should be more open to help us with, the computer modeling and statistician probably more. to understand what's actually happening in front of us. And if you look at these two classes they described, I wouldn't have picked the definition of these two classes based just on experience. I wouldn't have gone from experience and said, yeah, I know in ARDS we have two classes. No, we needed actually the help of the computer modeling to understand it. So I think it's time to open that Pandora's box and see what's coming out there, and seek assistance from the guys who know how the stock market may evolve, because they have computer models predicting it. So we may as well in mechanical ventilation use fuzzy logic as well to understand how we should ventilate.
I tell you, it's great. I've been thinking about something for some time. If you look at the intensive care bedside chart, this is the work of love by the nursing staff. We still use analog charts, but most places in the world have them in electrons and phosphors, or whatever you want to call it, LED micro, whatever that is on the screen. The problem is that the ICU chart does not tell the story. I've been trying to do an audit with a student this summer, and the simple moot is this: are we using fluids correctly? So I thought, well, it wouldn't be too bad. I've gone through a whole decade of our ICU charts with and it's covered something like 70,000 patient days, and pulled out about 900 odd days where they've had cardiac output monitoring. And then we've looked at fluids around that. I thought, oh, that might be vaguely useful to look at. Can I tell, even if I've got a cardiac output monitor in a patient, from what is written down, whether or not the fluids were correct or appropriate? Well, no, you haven't a hope. It's because the charts don't record all the transients. They don't tell you whether the patient was fluid responsive. And so what the nurses do is they write down what Florence Nightingale taught them 150 years ago: the blood pressure, the temperature, and the pulse rate at the top of the hour. And they write down the ventilation mode every bloody hour. For some strange reason, it must be a bit of OCD on their part. And they write down the PIP and the PEEP and all that sort of stuff. And that's it. And if you look at the chart, you've got no friggin' idea about what's going on. And so here is a problem. The ICU chart needs a total redesign. It needs to pick up the things that we're talking about in ventilation, the things that we think are important. It needs to be recorded, because here is the test. If I look at my ICU chart and I cannot tell and I cannot audit the quality of care, then what the fuck, excuse my French, why did you ever bother writing these things down in the first place? It might have served a medical legal purpose, but it serves no other purpose for in any investigation or any audit. Therefore, it's pretty much a complete waste of time. So when it comes to CVS, I want to know if patients are fluid responsive. A very simple question. What is their pulse pressure variation, or systolic pressure variation, or their stroke volume variation? That might be helpful. But oh no, that's never written down. Did they respond to the last 250 mils of fluid? No, I wouldn't write that down. And when did give the fluid? Well, I don't know. That was given sometime the last hour, and the urine output. That's bloody useless anyway at the best of times. So we cannot make progress in intensive care until we rethink our ICU charts, rethink of the data that we collect from them, and completely revise the way we think about the package of ventilation and how we think about everything else, all that supportive stuff that we do for patients. I wonder, so it's a huge problem. It's not little, it's huge. And I'm trying to work out what the tipping point would be. How could we start to make changes in that direction? But I think the first thing is, I reckon we all, and Andreas, you came in after I made this comment, I think we've got to write a paper on this. We've got to turn this talk we just had into a paper that says what the fuck's wrong with what we're doing. It's not just ventilation. Ventilation is a beautiful exemplar of everything, but it's not just ventilation we haven't got right. We've got cardiovascular management hopelessly bad. It's not changed the size of registrar. Patients have been hypotensive. What do? We give them some fluids until we think, shit, we're giving them too much. We'll give them some minotrope now. And that's about it. That's about the science. There's not much more to it than that. And it goes on and on and on like that. We never actually get beyond that. And our ICU charts can't tell us, and we record the wrong information.
So just get rid of the paper. Get rid of the paper. There's your mistake straight away, and have everything electronic coming in that can record and compress it into a trend.
We need that, but we need to understand the physiology and understand what's important to record.
That's right, but you don't look at one value.
Yeah, that's
what
true.
You're saying you're giving fluid, pump talks, whatever.
And you need models. You might have electronically, statistically draw regression lines in your blood pressure, or you might want to know what period of time that your blood pressure is above or below a certain limit. That's pretty simple bit of stats. But I mean, I've seen the latest Codman ICP monitor now draws little histograms and tells you what the ICP has been like, and it gives you actually some much more information than you get if you just looked at the bloody ICP. But we don't even have that in other parameters. What do you like to see then in ventilation? How many times do the patients, how many times do they falsely trigger, for example?
I have just a couple of points actually to what Jeff is saying. Like, yes, even sometimes the EMR, the electronic medical records, don't even like pull what you need. So yes, it's on the computer or whatever, but you can't. It's exactly like a paper chart. But so I'm sure there's more sophisticated ones than the ones that I currently use. But at least the trend is like, say, in mechanical ventilation is, if you want to see like the things that you say, like the mistrigger or the synchrony, and the ventilator give you the last 7 days of like trend, and you can trend it. So we're moving to that right direction from some aspects. And I don't want to be always negative about mechanical ventilation. I kind of like usually pessimistic. But somebody told me like we were just out of the dark ages like 400, 500 years ago. And when you think about it in the span of history, actually we did pretty good, I agree that artificial intelligence is the solution. I think it's smarter than me and always, there for the patient. Even if I'm like smarter than that, I can't stand 24 hours on the ventilator. So I definitely think artificial intelligence will dominate. Maybe it will take over that. We don't have to teach clinicians anymore because now the ventilator is doing most of the work. The other thing is, when we compare, especially when you talked about the cardiac ICU and the flows and stuff like that, think about it. Not much has been in artificial intelligence like we have now in ventilation. Compared, like there is no machine like all these machines that measure the cardiac output and the SVV and the PPV. They don't tell you like, give the patient fluid, or they increase the dose of medication of the inotropes to improve your cardiac. In mechanical ventilation, we actually started this way, like with AVM, ASV, all this artificial intelligence. So I think we are moving in the right direction. Eventually, we're going to be there. Even artificial intelligence, I think, is still in its infancy. I'm sure like 20, 30 years from now, whatever we're using or think of as artificial intelligence, we're probably going to be obsolete and like sounds, So I'm trying to be hopeful here, just trying to see like, I think we're in the right direction, but might not happen in our lifetime. But I'm probably totally wrong, but that's
Okay. So it sounds like we have an opportunity to put a paper together, but it also sounds like we need to make this a movement besides a paper, or to use that paper to leverage. And my feeling recently has been I don't mind calling something what it is. And right now, what's happening with mechanical ventilation, which is at least the scope I have, is not working. And we need to be open about that. And we need to let people know that it's unacceptable at this level. I think the paper serves as a foundation for where we want to head, a directional description at first, but we need to kind of flip the tables over, if you will, or what is it? Yeah, turn the tables over, if you will, and upset some people, I believe, because the current course isn't really working out. And if that requires pounding on the heads of regulators as well, because simple tools that we need are not available to us still, then that should be our cause. So I think this is really a call to arms, for lack of a better word, and it's a call to action for mechanical ventilation. And let's take it upon ourselves to brainstorm off of this off of this recording and figure out as a team what we want to do to move some things forward. It starts one step at a time, and I think the paper is a good first step. So that's what I have. Anybody else have, want to make any final comments as we wrap this up?
Oh, I would say this, that I thought today's discussion was brilliant because, we've had some wonderful lectures, by, all the way through. It's been great. But this is a very frank and open discussion. And hopefully we can do a lot more like this on certain topics, just that, we want to talk about.
Yeah, look, I'm really excited by this. I've been thinking about this long and hard about what we're doing wrong in ICU, and it's not just ventilation. It's just about every bloody thing we're not making progress on. And I think this is I love your expression, Steve, a call to arms. That's exactly what it is, and that's what should be in the title of the paper that we write. A call to arms. ... What are we doing wrong with mechanical ventilation? And I think we need to also, use that as an analogy of many other ways we manage patients. It's not just ventilation, it's the sedation, it's the cardiovascular control. Those are important aspects as well. And they do impact, of course, with ventilation. Yep. So let's do it. Let's make that our first job next year.